Hi, my name is Jacqueline Probst, and with me is Rachel Christie, and today we are going to be talking about total hip arthroplasty. So this is just a nice picture representing the before surgery and after surgery, where you go from an injured hip joint to a metal hip joint. So a total hip arthroplasty is a surgical replacement of the hip joint with an artificial prosthesis. It is also a reconstructive procedure that has improved the management of those diseases of the hip joint that have responded poorly to conventional medical therapy.
Each year, over 150,000 hip surgeries are performed. 4.5 million people in the United States are living with an artificial hip as of 2010. 2.5 million of these are women, whereas 2 million are men. At 50 years old, the prevalence of a total hip arthroplasty is 0.7%, with increasing numbers every decade. California, Florida, and Texas have the highest numbers of total hip replacements each year.
So a typical candidate for a total hip arthroplasty will come to you with severe pain, loss of functional range of motion, failure of conservative treatment, and potentially a trauma. A candidate is younger than 50 years old or younger than 65 years old if they are active with good bone quality and no deformities. Typically, each patient will have a degenerative joint disease or osteoarthritis as seen on an X-ray, which is the gold standard.
There are three surgical approaches for the total hip arthroplasty. The first is a posterior approach in which the gluteus maximus fibers are split. This may result in an injury to the sciatic nerve, which will cause foot drop or loss of sensation. This approach usually has less blood loss, but the precautions are adduction, flexion, and internal rotation.
The second approach a surgeon might use is called a lateral approach, in which the surgeon will split fibers of the gluteus medius while the bulk of the glute med remains intact. Precautions include adduction, extension, and external rotation, which could result in anterior dislocation.
The third approach is the anterior or anterior lateral approach. In this, there's a split between the TFL and glute medius. The portions of the abductors are taken down, but then usually reattached. This also may result in an injury to the lateral femoral cutaneous nerve, which will cause decreased sensation. This is a minimally invasive approach, so there are usually no precautions.
As previously stated, there are many indications for a total hip arthroplasty. However, we're just going to concentrate on osteoarthritis. Some common signs and symptoms you may see in the early stages include pain, joint swelling, and difficulty with daily tasks such as climbing stairs, cleaning, and walking in the community. As the disease progresses, the pain worsens, while the patient may have difficulty rising from chairs, dressing, and even walking in household distances.
Clinical findings preoperatively for those with OA would be insidious onset of symptoms, a C sign of hip pain, also anterior groin pain, which may progress to posterior lateral hip or thigh pain, increased pain with weight bearing, morning stiffness, and relief with rest. Potential exam findings would be decreased range of motion, especially hip flexion and internal rotation, with stiffness and crepitus, a positive scour sign, and relief of the signs and symptoms, usually pain with long axial distraction of the femur.
Postoperatively, when a patient comes into the clinic, they will generally present with soreness and pain typical of a recent operation. However, potential exam findings include decreased strength in the gluteus medius, gluteus maximus, and quad strength. They will have overall decreased hip range of motion and potential sensory and motor losses if a nerve was injured.
The physical therapist's role for a patient with a recent total hip arthroplasty is to guard against dislocation, gain back functional strength in the hip and knee, prevent or minimize side effects of immobilization, teach independent transfers, obtain range of motion, and support the family and the patient emotionally.
Immediately after surgery, while still in the hospital, PT quickly maximizes the patient's function, which is associated with a greater probability of earlier discharge, which in turn is associated with a lower total cost of care. This is another way for PTs to prove ourselves to the healthcare system, showing that we can decrease costs. This article here that we have referenced is called Perioperative Exercise Programs to Improve Early Return to Function Following a THA. These subjects were randomized to either an exercise or control group, and they used a 25-meter walk test and a 6-minute walk test as outcome measures. The exercise group demonstrated greater stride length and gait velocity 3 weeks post-surgery. To follow up at 12 and 24 weeks, The exercise group gained even further gait velocity and greater improvements in the 6-minute walk test.
Goals in the post-op clinic include relief of pain, prevention of dislocation, increasing the independence and functional mobility, preventing muscle wasting of the involved limb, maintaining muscle strength and endurance of the uninvolved limb, and corrections of gait.
Some gait deviations you might see include a larger step length on the involved limb, a shorter step length on the uninvolved limb, pelvic drop and stance phase on the involved limb due to a weak gluteus medius, knee flexion during the stance phase on the involved limb due to decreased range of motion in that hip, and early heel rise to propel the patient forward. Weight-bearing precautions typically are weight-bearing as tolerated. However, depending on the weight-bearing surface of the metal placed into the patient, sometimes they might have partial weight-bearing up to 6 weeks.
Often the surgeon will provide physical therapists with a typical protocol for exercises and how to progress those exercises and when. For the first 6 weeks, the typical exercise program will focus on protection. This means decreased pain and swelling, achieving hip flexion of 90 degrees, and improving all range of motion. Muscle strength of the hip girdle, including mostly hip extension and abduction, proprioceptive training, functional activities, and improvement of general body weakness, trunk, and uninvolved extremities.
From week 7 through week 12, function is the main goal of this phase. We want to encourage the patient to regain normal gait, achieve symmetrical hip range of motion, encourage the patient to be able to ambulate for 20 minutes, and perform a sit-to-stand without hand support. The patient should be able to return to all functional activities by week 12 and potentially begin light recreational programs like walking or pool. By the end of this phase, the muscle manual testing should be able to reach 4+ out of 5.
For months 3 to 6, the goal is to return to activities, whether it's a recreational sport or work. You also want to continue to enhance strength, endurance, and proprioception.
In order for a patient to be considered for discharge, they need to be able to perform gait independently. They need to be able to perform a step-over-step stair climbing technique, along with having pain-free active range of motion and at least a 4+ out of 5 manual muscle testing of the lower extremity. They need to have balance and proprioception that is appropriate for their age range and be able to perform their exercises for their home exercise program.
Complications following the total hip arthroplasty surgery can be prevented with careful post-op care and management. 90% of working patients who receive a proper rehab will return to work.
Like Rachel said, complications are uncommon. However, if one arises, it might be as a dislocation, which only occur 1 to 5% of the time. This is typically seen in patients that are 80 to 85 years or older of age, more common in females than males, who are non-compliant with their precautions and rehab procedures, along with potentially having cognitive deficits such as dementia. They might have had a previous hip surgery or have neuromuscular disorders like Parkinson's or polio, or potentially have alcohol abuse issues. Sometimes malpositioning or component loosening can occur. However, surgeons will quickly take an x-ray after surgery to ensure that everything is in the correct place. These components can last up to 15 to 20 years, depending on the activity level and the wear and tear on the surface.
Other complications include femoral fracture, nerve injury, which may result in foot drop, deep vein thrombosis, pneumonia, poor wound healing, leg length discrepancy, or infection. Most of these are found and caught at the acute stage.
So here's a list of outcome measures that we have found. The first 2 are functional measurements, and then the last 2 are quality of life measurements.
The LEFS is a functional scale to measure lower extremity muscular dysfunction. This can be used for hip disorders including hip OA and THA. The MCID for this scale is 9 points.
So this is the SF36, and like the title says, there are 36 questions, and this is used to measure functional health and well-being. Unfortunately, according to a systematic review, the MCID cannot be determined based on limited precision and has not been validated.
The WOMAC test is used to assess hip pain, stiffness, and physical function. It consists of 24 questions in 3 subscales. Just like the previous test, the MCID has not been validated and has limited precision.
Thank you for your time. We hope you thought our presentation was hip.